Welcome to this webinar on air polishing in the orthodontic patient. We look forward to providing you an informative program that is based on scientific evidence and hope this will enhance your practice with the orthodontic patient. Air polishing has become a mainstay in the realm of tooth polishing and has an array of patient applications. Air polishing is considered a polishing method of choice for the removal of heavy stain and dental biofilm, implant patients, periodontal maintenance patients, and especially the orthodontic patient. Polishing of all types as part of the oral prophylaxis has undergone a sea change in the past 4 decades in terms of justification, infection control, types of equipment, and polishing agents. Dental hygienists have been faced with issues, many of which were not anticipated with a procedure that was once considered mundane. We had to ask ourselves, should we polish or not polish? We have had concerns about splatters and aerosols. We have cleaning agents that are alternative to polishing agents. And notably, we have a once considered futuristic polishing method, air polishing, that is now a standard in practice for the oral prophylaxis polishing procedures. Plus, we have a new array of air polishing powders that provide dental hygienists selections to meet the patient's individual needs. No doubt, the largest controversy to ever affect traditional polishing in terms of justification has been the degrading of traditional polishing as something that could be interpreted as causing more harm than good. This theory was called selective polishing. Unfortunately, selective polishing was scientifically unsupported and was an undeserved degradation due to the adoption of a single abstract that described pilot laboratory research on traditional polishing. A complete study was not conducted using the protocol described in the abstract. The investigator inappropriately concluded that millimicrons of enamel were removed during traditional polishing procedures, and this pilot research was fraught with issues, such as the speed of the rubber cup was never varied to a slower or faster speed, the amount of pressure on the prophylaxis angle was never varied to a lesser or greater amount of pressure, and the hardness of the primary abrasive particle was never disclosed, as well as the fact that some facts regarding the methodology were not disclosed at all. Summarily, selective polishing was not based on scientific evidence. The concept of selective polishing was never supported by in vitro or in vivo research, nor was the concept recognized by organized dentistry or dental hygiene. The definitions of an oral prophylaxis as defined by the American Dental Hygienists Association, the American Academy of Periodontology, and the American Academy of Pediatric Dentistry have always included tooth polishing for the removal of dental biofilm and stain. Essential selective polishing is a term coined by Barnes that incorporates tooth polishing procedures based on the patient's individual needs. Tooth surfaces are polished with the appropriate agent for the dental biofilm and stain removal. Dental biofilm and staining are removed with a cleaning agent, the finest grit of polishing paste, or air powder polishing that is effective for meeting the patient's needs. As dental hygienists know, hundreds of millions of dollars are spent annually by patients looking to achieve that perfect, bright, and shiny smile. Patients expect to have their teeth polished and worldwide claim the procedure to be their favorite as part of the oral prophylaxis. Simply, patients expect to have stain and biofilm removed by tooth polishing, and they are quite fond of the smooth feeling that their teeth have when their teeth are newly polished. Polishing, scientifically, involves several complex aspects, many of which are interdependent. The polishing of teeth and dental restorations is important for patient satisfaction and for the success in the prevention and treatment of oral disease. In abrasive science, mechanisms of polishing that use abrasive particles are part of tribiology, a discipline associated with physics, chemistry, material science, and surface contact engineering. Specifically, tribiology is the science of interacting surfaces in relative motion. It incorporates the study and application of the principles of friction, lubrication, and wear. From a material science perspective, polishing is intended to produce intentional, selective, and controlled wear. Within the science of tribiology, polishing is classified as two-body abrasion or three-body abrasion. In two-body abrasion polishing, the bound abrasive particles are solidly fixed to a substrate. Examples of two-body abrasive products are rubber cups that are impregnated with abrasive agents, or there are polishing burrs that are made of abrasive agents that are applied directly to the tooth surface. Therefore, two-body abrasion does not require a polishing paste. Three-body abrasion involves loose abrasives that lie in an interface between the surface being polished and the polishing application device, which in the case of dental polishing is a rubber cup, especially when considered in the realm of traditional polishing. So a polishing agent is required. Air polishing is also an example of three-body abrasion. In air polishing, loose abrasives move in the interface between the surface being polished and the polishing application device. The air, the powder, and the water are propelled by kinetic energy against the tooth surface, removing the biofilm and stain. We often, however, need alternatives to polishing with heavy abrasives. Many patients have no need for heavy abrasives used in traditional polishing. Examples are patients with aesthetic restorations, some that are all but clinically undetectable, which makes restorative charting and current radiographs essential prior to any type of polishing, and patients with highly inflamed gingival tissues and peri-implantitis, and certainly the orthodontic patient. The orthodontic patient presents with many challenges that are integral with orthodontic brackets, bands, and wires. The orthodontic structures present major obstacles to keeping the oral cavity clean. Therefore, many orthodontic patients present to their maintenance appointment with the oral conditions such as this patient has. Note the erythematous gingiva, especially at the margin that spontaneously hemorrhages, the thick supragingival biofilm covering the cervical one-third of the tooth, and the absence of interdental papilla. There is a polishing solution for these patients, and the answer is air polishing. Note the absence of dental biofilm and stain in this patient who's been treated with air polishing on a regular basis for several years. The gingiva is normal in color, and the interdental papilla are present. Nearly 100% of biofilm and stain removal is possible for the orthodontic patient. There is quite a body of scientific evidence regarding air polishing And first, it behooves us to compare the science of air polishing versus rubber cup polishing. How does it compare? Both are therapeutic in that they remove biofilm, which promotes healing and health. Air polishing is more efficient, requiring less time than rubber cup polishing. In fact, it's less than half the time. Because air polishing does not require two-surface contact, there's no generation of heat. And since it requires less time, it decreases operator fatigue and increases patient comfort. There is greater access to all areas of the tissues. It reaches pits and fissures and all areas around brackets and bands. Air polishing was introduced in 1976 and has a body of science that is significant in depth and breadth. Air polishing produces uniformly smooth root surfaces, much more so than hand instruments or ultrasonic scaling inserts. It removes biofilms, endotoxins, and stain from hard-to-access areas. It is not detrimental to implant materials and is the method of choice for treating peri-implantitis and perimucositis. Nearly 100% of stain and biofilm from hard-to-reach areas for the orthodontic patient is possible. Okay, additional scientific evidence. Air polishing saves time that can be used for patient education or additional therapeutic treatment. It will not disrupt the bond between the brackets and the tooth or the bond between the cement and the metal band. It will not disrupt the surface characterization of aesthetic dental materials with the use of an appropriate air polishing powder. Orthodontic patients present with quite a few challenges, such as this individual, who presents with oppressive, viscous dental biofilm and stain. Additionally, heavy gingival inflammation that can possibly have periodontal involvement and sensitive tissues. When tissues become quite sensitive, it becomes very difficult for the patient to want to clean them because of the discomfort involved. Therefore, if they don't brush or clean properly, the situation gets challenges, including decalcification that can become cavitated surfaces. It is nearly impossible to access tissues with traditional polishing methods, and there is a need for frequent recall with the least abrasive biofilm and stain removal possible. Parts of the armamentarium of air polishing, which is the powders. Air polishing was introduced in 1976 with a sodium bicarbonate air polishing powder. For over a decade, it was the only air polishing powder available. In 1988, aluminum hydroxide was introduced as dental hygienists had requested a sodium-free air polishing powder. In 1995, calcium carbonate was introduced, and then there was a period of time where there was little to no research on air polishing powders. But in the year 2000, there was a renaissance in air polishing powder research, which continues today. And now we have more than doubled the number of air polishing powders available. Glycine has been introduced, calcium sodium phosphosilicate, a new formulation of sodium bicarbonate, and erythritol. Some other newer powders that include their generic and trade names are 3-MTCP, which is a specially formulated calcium carbonate, calcium sodium phosphosilicate, which is known as Osprey Silk, and contains a brand name of bioglass called Novamin. Glycine has two formulations that is manufactured by EMS, the Airflow Perio and the Airflow Soft. Erythritol is known as EMS Airflow Plus. EMS also has a less abrasive formulation of sodium bicarbonate compared to the traditional sodium bicarbonate powder that was introduced in 1976. It's interesting to look at the shapes of the air polishing powder particles. Some are geometric in shape and some are round and smooth. Some people surmise that because of the geometric shape, those powders would be more abrasive. Well, that separates fact from myth. Some people think that the hardness is determined by the material used, and some people think that it's the shape and size of the powder that determines the hardness of the particle. In fact, it is the material that determines the hardness of the particle, not the size and shape of the particle. In a highly objective in vitro investigation, Barnes et al. Investigated a comparison of the effects of calcium carbonate, calcium sodium phosphosilicate, glycine, erythritol, two different brands of sodium bicarbonate, and aluminum trihydroxide. The study was conducted utilizing an automated system, so the exposure times to the powders were exact. The material samples were kept in constant circular motion, and the handpiece nozzle was 4 millimeters from the surface of the sample. Each powder was used on hybrid composite, glass ionomer, and human enamel for 1 second, 2 seconds, or 5 seconds. To illustrate the 5-second and 2-second photomicrographs, so the clinician can see the amount of abrasion created by each one of these powders or lack of. As you can see, aluminum trihydroxide is highly abrasive. Of these three materials, the hybrid composite, the glass ionomer, and the enamel, glass ionomer is the softest material. You can see that it even has, after 5 seconds of use, has removed some enamel. It is important to note that the small, dark, round holes in the glass ionomer material have not been created by air polishing. That is the material characteristics of glass ionomer. Calcium sodium phosphosilicate is the most abrasive of all air polishing powders that have been marketed to date. As you can see, it ate a hole through the sample of the composite, the glass ionomer, and it ate through 10 microns of enamel after 5. Glycine, on the other hand, is scantly abrasive, in fact, non-detectable, with the exception of glass ionomer, which is, as stated previously, a very soft material, and it's highly porous by its nature. Erythritol, on the other hand, leaves non-detectable treated surfaces. It is the least abrasive of all air polishing powders and can be considered, at this point, a universal polishing agent for air polishers. When all the powders, times, and materials were analyzed in this study, which also included profilometry that measured the surface roughness of each sample, the overall roughness produced from least abrasive to most abrasive was erythritol, least abrasive, then glycine, then EMS classic sodium bicarbonate, Dentsply Profijet sodium bicarbonate, and Cavo Profipearls calcium carbonate, Dentsply Jet Fresh aluminum trihydroxide, and Osprey Silk calcium phosphosilicate were the most abrasive materials. I want to focus on air polishing powders exclusively for use in the orthodontic patient. As stated, erythritol is not yet available in the United States, but will be soon. Currently, glycine is the ideal air polishing agent for the orthodontic patient. To clinically prepare for the orthodontic patient and air polishing, the operator uses a standard protocol of protective outerwear, glasses or a face shield, a mask, and gloves. For patient preparation, the first thing that should occur is the recording of the health history. The patient should use a pre-procedural rinse. They should be draped or have a bib. A non-petroleum lip lubricant should be utilized, and there should be adequate eye protection for the patient. Importantly, disclosing agents are highly useful in air polishing. It is important to remove as much biofilm as possible, especially in the orthodontic patient where it's difficult for the patient to clean effectively and will likely have gingival inflammation. Disclosing solution will assist the hygienist in seeing and therefore being able to remove as much biofilm and inherent endotoxins as possible, which is therapeutic for the patient and promotes faster healing. It is important to emphasize that the patient disclose their own biofilm in their home care regimen. Be looking for new dental disclosing agents on the market which are not as messy or as difficult to remove as the original disclosing agents were. Now we're going to watch a short video of the clinical application of air polishing with the orthodontic patient. Please note that there's a variety of handpiece positions that are used to effectively remove the disclosed biofilm. The handpiece is angled toward the incisal or occlusal and or the gingival margin at approximately a 30 to 60 degree angle. Please note that the air polishing handpiece is kept in a constant circular motion, and the tip is approximately 3 to 5 millimeters from the tooth surface. Adhering strictly to handpiece regulations when air polishing the orthodontic patient is not necessarily required, as it takes a variety of angulations to complete the biofilm removal. In this particular case, we're using glycine. As you can see, the air polishing powder is all but non-detectable. It is very, very gentle and extremely comfortable to the patient with no stinging or discomfort when the air powder polishing spray comes in contact with the gingival tissues. High-speed suction is recommended at all times for aerosols in air polishing and to enhance the comparison of the patient prior to and after the air polishing. Notably, in the post-treatment photograph, cavitation of the enamel surface can be seen, an indication that this patient can benefit from professional strength fluoride as well as fluoride application for home use as determined by the dental hygienist. Orthodontics are not just for children anymore. With multitudes of adults seeking aesthetic restorative dentistry, likewise, they have chosen orthodontic treatment to enhance their smiles and dental function. Further, many children and teenagers with chronic diseases are now treated on an outpatient basis, so many children who have chronic diseases may have access to orthodontic treatment that otherwise might not be possible. Whether youth, teenager, or adult, precautions should be taken with patients who have the following types of diseases: chronic obstructive pulmonary disease, which can include asthma, bronchitis, emphysema, the flu, lung cancer, pneumonia, and pulmonary edema; patients with end-stage renal disease; patients on long-term steroid use; immunocompromised patients; and patients with communicable diseases. Additionally, patients who are on a physician-directed sodium-restricted diet. However, sodium bicarbonate powder has been scientifically proven not to affect blood levels of sodium. All of these diseases are serious, and a medical consult should be acquired if there's any question regarding the use of air polishing with any equipment or any type of powder. That can occur when air polishing is used, which is called facial emphysemas. This occurs when air that is compressed becomes entrapped in soft tissues. It occurs when compressed air and/or compressed air and water are used in the vicinity of an open surgical wound, such as an extraction site, or a site that's recently undergone oral surgery, or it can occur when compressed air and water is directed into a severely deep periodontal pocket in which the tooth has little or no bony support. Facial emphysemas do exist, and they should be treated. Their symptoms include a swelling of the face. It may include swelling of the eyes. There becomes a shiftable swelling so that when the face is pressed on, air can be felt moving around within the tissues, or there can be a popping sound called crepitation. The standard treatment for facial emphysemas is the use of antibiotics, notably cephalosporins. Facial emphysemas treated in this manner usually resolve within 72 hours with no remaining effects. There is a possibility that subcutaneous facial emphysemas can be fatal, and treatment should be initiated as soon as possible. However, it must be emphasized that it is highly improbable that facial emphysemas will turn out to be fatal. It's just a possibility.
Please just read what you have if you have like no.
Okay, here are some examples. Dental hygienists can enjoy many types of air polishing equipment now, from handheld to tabletop to air polishing coupled with ultrasonics. It is important to note that not all brands of air polishing equipment accept all brands or particle sizes of air polishing powders. Please consult with your manufacturer of your equipment regarding recommendations for powder use.